Thank you. It's great to be here as always. Those of you who come to this meeting regularly probably aren't in the room now. They speak almost every year. So I'm talking about communicating with the public about strabismus surgery and about what we do.
Yeah.
So those of you who have seen me before know that I like to start off with some things that I assume going into the talk I'm about to give. Also, if my battery runs out before I'm finished, I like to say now, you're welcome. You may not believe this, but I do assume that most doctors believe they are always acting in the patient's best interest. And they're trying to do what they think is appropriate and the best care that they know how to provide. Most people just struggle to move outside of their comfort zone. That means that goes for patients, that goes for doctors. Damaged eye muscles are extremely rare, though you wouldn't know that by the amount of strabismus surgery being done. And some parents and patients are not ready to devote the time and or effort to help themselves and prefer someone to fix them. We all deal with that all the time. They want something quick and easy. They want somebody to do something to them so that they don't have to take responsibility for their own change. That's common, but it's becoming less and less the norm, I think. But strangely, many parents and patients are uncomfortable with surgical procedures and are seeking alternatives. And thanks to the internet, there's a lot more access for people to find their own information and start to educate themselves and figure out what it is they really want. And this would be a surprise to everybody that vision therapy has an excellent track record in treating all types of strabismus. So how do we talk to real people about strabismus? This is one way. So thank you for your time. Are there any questions? Actually, I'm going to ask a bunch of questions myself, and I'm going to answer most of them as well, but you can just sit back and relax. So what isn't strabismus? It is not, in most cases, the problem. It's an indication of the way the person has attempted to solve the problem, which was the less than adequate ability to develop and use a visual process efficiently and effectively for normal visual demands. I hope most of you know that in this room. I think you do. Strabismus is not, in most cases, an eye muscle problem, at least prior to the onset of strabismus surgery. So the debate was, for a long time, I think it still is, certainly in 100 years, thanks to the work of Dick Brunick, the discussion may change a little, but is it a sensory etiology, is it a motor etiology? But it might be a response to spatial processing deficiency, inability of the brain to adequately interpret and respond to the external environment, or difficulty with motor integration. So again, it's not so much a muscle problem, but a processing problem of understanding the internal environment. And so you don't have good communication between the brain and the body. So it's not sufficient to talk about the eyes without talking about the brain and the role in the visual process. Similarly, it's insufficient to talk about the brain without talking about the role of the entire body. So development, movement, learning are intimately intertwined. It's insufficient to talk about the body without talking about the role of the person. So that's the physical, the psychological, emotional, developmental, environmental milieu. When does strabismus develop? It can be present shortly after or at birth. Generally emerges early in life, and it can appear secondary to an illness or injury at any age. It can also remain in hiding for any length of time. I'm sure most of us have seen people in their 40s, 50s, 60s, maybe even older, that seem to have what to them is a sudden onset strabismus. They're suddenly symptomatic after all these years, and obviously the first thing, that's sort of a red flag, but it seems that they've been hiding this for many years, and they've been fighting it without realizing it for an entire lifetime, because it's not a cosmetic issue, so nobody tends to pick it up unless there are symptoms. And so those symptoms can emerge at any time in life without being anything systemic or dire going on underneath. It's just that they ran out of gas, because they've been fighting this for so long, and it takes a lot of energy, as we all know, to make your visual system work when it's not just working on its own the way it's meant to. So why is strabismus?
Why?
I ask a lot of questions, as I said. I have a lot more questions than answers. As I said, it can appear secondary to an illness or an injury, and neither surgery nor vision therapy can remove the insult, but we can help people use what they have to a greater degree. And that's the important part, and certainly we've heard more about that this weekend with some of the new information we're getting. And strangely enough, we can do this non-surgically. So when the eyes habitually deviate from the expected, one of the following response options is quickly pursued in the name of survival. Random attempts to compensate. The organism will access whatever possibilities are in there, changing accommodation, changing binocular status, changing refractive status. All these things can, peripheral awareness, all these things can be brought to bear, but usually for the average human, it's sort of a random event of trying to problem solve and find a way to survive and live easily with what they have to work with. There can be a pattern attempt to compensate. So in certain environments, they may have certain maneuvers that they make. Again, still fairly random, but they may start to develop patterns of adaptations to try to cope with this. They can ignore the problem. And of course, avoidance of looking and or moving. So you know, lots of little ones that don't do any kind of sports. They don't like moving around because they're uncomfortable understanding their space world. Or a great career in comedy. So where is it? As I said, it's rarely an eye muscle problem, although we have some new information now that maybe there are some issues with the structure of the muscle. But up until now, that's not been considered. It's just, you know, eye muscles can be moved and reinserted at any place at any time. So it can be a muscle problem at the outset, but damaged eye muscles, again, are infinitely less common than the number of eye muscle surgeries that happen. It's better thought of as a brain problem. And the cosmetic strabismus is often less disruptive than those smaller strabismus that nobody can see from the outside, but it's often easier to make a gross adjustment than the fine tuning. Make those little adjustments is often more difficult, and I think those small adjustments tend to create a situation where you're constantly fighting it, whereas if you have an overt strabismus, you can make a choice much more easily. I'm just not going to use that channel. I'm just going to work with what's easy to do. But when it's much smaller, you're going to try to keep, there's that need to try to use all the equipment to the best advantage, and that takes a lot of energy. So how does it start? As I said, might be problems dealing with gravity, with body awareness and movement. Laterality issues, fine motor problems, gross motor. There can be problems with spatial processing. They don't understand the space world, so they're not getting good input, and they're not getting good feedback and output to try to use the channels in an appropriate manner. And of course, there can be an accommodative component, as with accommodative esotropia. So that's often treated, well, they'll still do surgery for those, but often they'll try to stifle it with lenses. And my thinking with lenses is often try to avoid prescribing a lens that will do the work. I don't want the lens to do the work. I want the person to figure out how to do what they need to do more efficiently and more effectively. And so I'm going to try to use a lens more as a catalyst to provoke changes internally rather than just try to mask it with a crutch. And they're almost guaranteed to be eye movement issues. So damaged muscles do in fact exist, I will admit that publicly. But even that doesn't mean that there's no way that we can have a positive impact on the situation. So what is strabismus? According to the American Association for Pediatric Ophthalmology and Strabismus, they say it is any misalignment of the eyes. So what are the types of strabismus? You have constant unilateral or bilateral, intermittent, of course, alternating, convergence insufficiency. I put that in there. It's a misalignment of the eyes. So according to their definition, why is that not considered a strabismus? Aphoria. I was taught that is a latent strabismus. I don't know what that means, but it sounded good. So they're still dealing with inability to align the eyes in many circumstances. And I don't imagine that it's impossible that a surgeon would want to treat aphoria surgically. Yes, and how does this aphoria, when does it get upgraded to an actual strabismus? I don't know the answer to that either.
Steve,
So these are types of strabismus.
what's the difference between a bilateral strabismus and an alternating strabismus?
The question is, what's the difference between a bilateral and an alternating strabismus? Bilateral being both eyes turning out or in at the same time, as opposed to the person being able to align one at a time and maybe switching from time to time. I had a patient, an adult patient, in her mid-20s who had a constant large angle alternating exotrope. So she could aim each eye at any time. There was no reason why she would choose one eye over the other that either she or I could determine. She was easily comfortable in either mode. Both eyes could see clearly. Neither eye had stereopsis though, so that was a problem. So we thought we would try to work with her first and see if we could get some sort of movement. It didn't really happen. So we talked about the possibility of surgery at that point, and she decided to go ahead and do that. And I said, well, you know, and after the surgery, you're going to want to come back in here so we can help your brain figure out what the surgeon just did. So she did that. She got the consult and came back, and she was very upset. She said, the doctor is going to operate on both eyes, and I don't want that. I said, well, I don't know why that would be the choice, so let me talk to the surgeon. And I called up and I said, well, she's very concerned. She doesn't want both eyes operated on. He said, well, why would I do that? And I'm thinking, well, why would you pick one eye over the other? They're both equal. So how do you decide where you're going to go? He said, oh, no, we're only doing one eye. I said, okay. So I assured her that that was what was going to happen. And she had the surgery and came back. And she was even more upset because they operated on both eyes. And one eye was continually bothersome to her. Now, that may have been because she didn't want it done and something emotional happened to create that. It didn't matter to me at that point. There's water under the bridge. So we just said, you know, I'm sorry, I thought we had that straightened out. She came back in therapy, and I still remember the moment that she saw 3D, because I was in a different room at the moment, and I heard her jumping up and down and screaming. She had never, to her knowledge, had never seen any 3D in her life. So that was exciting. But, you know, surgeons are unpredictable. So hopefully this is not copyrighted. I got this off of the internet from the ICD-9 So no more easy diagnoses for exotropia. You have a laundry list now, and you also have the ESO. My question is, why is there nothing on this list about consecutive esotropia or exotropia? Why is there nothing about post-surgical strabismus? Those should be diagnoses that we should be able to hang our hat on. So who thinks they know about strabismus? Anybody? Dave? We do. And we're not alone, because the AAPOS does as well. And that is that doesn't make any sense. Who is AAPOS? That's the American Association of Pediatric Ophthalmology and Strabismus. And their organization's goals are to advance the quality of children's eye care,
And suppress it.
support the training of pediatric ophthalmologists. I didn't realize ophthalmologists could be that young, but as times are changing. Support research activities in pediatric ophthalmology and advance the care of adults with strabismus. So they've expanded their scope to damage adults as well. I mean to operate on adults as well. So this is from their website. They got the lazy eye and all the good stuff up there. If you're interested, I have a blog on my website, a blog post on my website entitled "Who You Call Lazy," because I came to think of the lazy eye as a heroic eye, because it's giving itself up for the greater good. So to me, there's nothing lazy about that. It's survival. So how do they talk to real people about strabismus? Surgery is the only option. And it must be done immediately. And without surgery, the eye might go blind. Anybody heard that one? Even with amblyopia, they want to do surgery on the eye because it will go blind.
Where did they get that one?
I don't know, because I would think sticking a knife in your eye could make you go blind too. And surgery is the only treatment, even though the eye turn is intermittent. I don't get that one. So what else are the ophthalmologists saying? I don't know if anybody's heard this one. I've heard it several times. Not recently, but I've heard it a few times. There's nothing wrong with your child's eye muscles, but that's how we fix it. Has anybody heard parents come in with that one?
Yeah.
It's relatively new. I think it's a move in a better direction. It's still not very far, but baby steps.
A few patients that end up coming to us then see the logic there, or the illogic in that.
I know.
That's how
I'm
they
glad they're
show
saying
up.
it. It at least allows parents to think, well, that doesn't sound like what I wanted to hear. So.
Wrongs make a right.
What else are they saying? So some of you may have seen this on the doc list, but you probably can't see it here. I know I can't. If it seems tight, weaken it. If it's loose, tighten it. If it is incontinent, MRI or CT scan is likely necessary. If it's a restriction, relieve the restriction. If it's paralytic, match the deficit. I don't know what that means. I don't want to know what that means, but that's what this was an ophthalmologist presenting a talk on strabismus surgery, and that's science.
That's fine.
And here's what an optometrist said after seeing that slide. It sounds like the amateur's toolkit: duct tape and WD-40. If it moves and it's not supposed to, use duct tape. If it doesn't move and it's supposed to, use the WD-40. So it was pretty similar. But, I don't know if you saw this recently, there was something on a story on the internet about a young infant who was in a car accident and had an internal, what they called an internal decapitation. The head was severed from the spine internally, not externally, and they were able to repair that. So it seems and that's not the first one. I read that there were several other incidents of similar injuries even in older folks. I think the oldest one was in their 20s, where they did the same procedure and reattached everything to a good outcome. So it seems like reattaching the head is much easier to be successful at than reattaching an extraocular muscle. So I don't recommend that for our patients, maybe for Dick's, but for ours it's probably not a great.
Well, they have less motility.
Well, apparently that's improving. The child they're going to get them out of the brace. And
No, I mean the head, even when it's attached, should have some less motility than the eye.
you would think. So how should we talk to real people about strabismus? We have to change the conversation, and I'm sure we all do that, and we have good ways of doing that. Everybody probably has their own language and their own favorite phrases to use to try to get the conversation moving away from the eye muscle and the eyeball to development and a visual process and a much bigger picture. And just tell the truth and the whole truth. And we can do that. I think most people in here and most of our colleagues understand that strabismus surgery has its place. There are times when, and I think that the woman that I described earlier was a pretty good case of that. I think I'm a decent enough therapist that I could have gotten her to get those eyes moving a little bit if there was a possibility of that. But they were so far out that I think she really needed the surgery just to get in the game at that point. And then we come in and we help to, again, as I said, help the brain and body figure out what just happened. We talk about development and the visual process and about other treatment options. And we certainly have many of those. And we talk about lenses. And it's maybe one of the more difficult topics for us to get across in this type of context, because most people's understanding of lenses is basically as a crutch, as something to mask a symptom, not something to stimulate the brain and the body and stimulate development and positive movement. But we know how to do that, and we've seen lenses do that in many cases. Most of us in this room, some more than others, but if you're not doing it, find somebody to talk to about how to use lenses in a more dynamic way. Probably the most powerful tool that we have access to, maybe that almost anybody has access to, is trying to help somebody use their brain in a better way. And obviously vision therapy. And in some cases, we talk about surgery. Now, I didn't write this in my book because I didn't necessarily want it to be in print, but I think of strabismus surgery as experimental or inadvertent brain surgery, because they are moving a part of the brain in a way that affects perception and affects performance and affects development. I wish they would think about it either that way, or that they would call it what it really is a cosmetic surgery, because then it would not be covered by insurance. And that's where it really needs to be. It's a cosmetic treatment, and then we can come in and make it a functional and developmental treatment process by doing the work that we do. And another thing we could bring up is the work of Dick Bruni. So as I said, in 100 years it's going to be commonplace that everybody will know about that, and hopefully you will have grandchildren who are in the profession who will be able to appreciate Dick's work. So we want to help parents especially ask the important questions when they get a surgical consult, or any consult. I don't want people to just take what I say to them on faith. I want them to think about it. I want them to understand it to the best degree that they're capable of, and to feel comfortable that it makes sense to them and they know why they're doing it, what they're getting involved in, and what the potential benefits could be. But they have to know what the questions are to ask. If you don't ask the right question, you're not going to get the information you're looking for very, very easily. So some of the questions might be, will surgery make the eyes work together? I don't know how they answer that, because some of my reading led me to think that, and this was some years ago, but I don't think it's changed a lot. I don't think that that really is something that they're overly concerned with, because I think that they know somewhere in there that it really is mostly a cosmetic procedure, and that they're just trying to make the eyes look straight, and they're happy when that happens.
But they actually are telling them in my area that that is how you make the eyes work together.
There is some, I know there is some of that. I don't know how prevalent that is, but yes. So how long will the surgery hold? I think that's a good question, Alex.
Yeah, I've had some say that surgery gets it close, then the brain does the rest.
And it does happen. It certainly happens.
Right.
But it's a crapshoot.
Right.
And that's not what you want out of your surgery.
Well, how do you know the brain's going to make it?
I think one of the reasons it's so complex, besides the things that Dick has told us about, is you've got this system that's tied, it's literally from head to toe. And it's tied into emotions, it's tied into balance and movement and future planning and everything we do. It's tied in intimately. And to just change all that by moving the eyeball and the head, it's not very likely that the organism is going to translate that into what we want them to translate it into, or what we know is optimal for them going forward. So how many surgeries will be needed? I think is a legitimate question. Because it's, I saw somebody with 10 surgeries. I know that's not the record, somebody had more, but this woman could barely move one of her eyes after all these surgeries, because they tried this muscle, that muscle, the other muscle, and eventually there was almost no movement going on.
Then they were straight.
Pardon?
Then they were straight.
No, unfortunately, that was not part of the outcome. So what follow-up care will be needed after surgery? This is another important question, and as Hans said, the follow-up could be your brain will figure it out. It can happen, but I don't think it happens all that often. So how can any surgery work without follow-up care? I'm not a real surgery aficionado, so maybe I don't know, but I don't know of any surgical procedures that don't include some sort of follow-up care, whether it be diet changes, lifestyle changes, physical therapy, things of that nature. So I don't know why they decided that strabismus surgery was the one thing that doesn't require anything other than just sit back and enjoy the show. So who's going to break the news to the brain? And why do you operate on perfectly healthy eye muscles? That's probably a dangerous question to ask, but I enjoyed it. And what could possibly go wrong? Again, a fair question, and a more reasonable question than maybe the other last two, but I think a parent is well within reason to ask that type of question, or an adult undergoing strabismus surgery. Yes.
I sometimes add to ask, for which position in space do they want to aim the eyes? Because it gets the parents thinking that you need them to move in all positions.
Yes, that's a good point.
And that'll be the answer, unfortunately.
All of that. It'll be for all.
Well, and that's similar to the point of why would you do surgery on an intermittent problem? The eyes are not always turned, and the person can use both eyes in the appropriate manner and use them that way.
Create a constant problem.
Because then you'll need more surgery. But these are good questions, I think, that people should be asking. And again, as I said before, this was one of the most amazing things I had heard when it came through the first time. I was kind of very surprised that a surgeon would say such a thing, because it seems to undermine their position somewhat. I don't know if they think it does, or they're just doing that for full disclosure, but I'm glad they're saying it. I wish they would all say it every time they consult somebody.
Steve? I think it's interesting. I had a case at SCO, a 70-something-year-old wearing a lot of prism. He didn't want to do therapy. He wanted surgery. Got him to a surgeon. I actually scrubbed in and watched the surgery. Did a 6 millimeter movement of a single muscle. Ended up fixing maybe 10% of the problem. And I still needed to put almost all the same prism back on. So I wrote to the surgeon, and he came back to me because the patient still wanted to pursue a surgical option. And here's what the surgeon wrote back to me. Because we were like, okay, you only did one, you got this amount, what about, I'm suggesting trying more muscles. And he comes back and says, operating on 3 muscles would not be a good idea, specifically because his response is very unpredictable and we'd be introducing more variables into the equation. Because he now has a divergence insufficiency, I think the thing, if we do another surgery, is to tighten the lateral rectus. But patients like him are very tough to fix. If the first surgery doesn't work, and it would have worked for 90% of the patients in this situation, the second one is also not likely to work. And now he shifts the focus. He says his brain stem is the problem, and we're trying to correct poor neural input with an end organ intervention.
Good for him.
I told him that I would suggest trying a slightly undercorrected prism and da-da-da-da-da, and anyway, it's like, if this didn't work, the first one, now I'll shift the focus, it must be something with the brainstem. I'm reading directly from the email from the surgeon.
Publish it.
Publish it?
At least he's acknowledging the role of the brain.
So the patient was so demanding, by the way, that he's scheduled to see another surgeon in town.
Well,
Okay.
if you don't get the answer you want, you find it somewhere.
Keep going, yeah, and I'll probably scrub in for that one too, just to watch and see what happens, and learning and making connections in the area. But it was very interesting that was the response of the surgeon, sort of shifting the switch around and
Good
that
for
kind
him.
of thing.
I'd refer to that guy.
We do.
Yeah.
He's the chief person we refer to, and he's a wonderful human being, and blah 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 blah. But it was just very interesting. I thought you'd like that as a response.
You made a point earlier in the lecture that with the internet and all the questions that are all the information that people are now having access to, and now they're going to have your book. Surgeons never really had to explain any of this. Now they're getting questions because there's more information they have access. They hear our voice a little more. And again, putting this out is we're going to hear a lot more different things. Surgeons in our area have kind of got backed off a little where they don't say, we're going to do surgery. We're going to say, listen, we're going to put them in glasses. If that doesn't work, we're going to patch them. And if that doesn't work, we have to do surgery. So the first week they wear the glasses, the second week they wear the patch, and then the third week But the thing is that the dialogue is going to change, and we're going to hear these things. It's not the muscles, it's the brain. But then they kind of have to figure out how they're going to float out of that. And as you keep bringing up more questions, they're going to have to come up with more.
Well, they'll say the eye is part of the brain and we're operating on the brain.
There you go. That's a good one. Don't let that out.
You better be careful. First one, common sense always seemed like the logical way to explain it from that point of view is not that the muscles weak, but that the eye is in this position, we're changing the position of the eye. And I always wondered why that wasn't their explanation in the first place. And it's hard to dispute that one. But I have another question for you, or a question for you. In regards to what can go wrong, I discussed with patients the subtleties of anesthesia. Okay, but in going through this...
Thank you.
All right, you're welcome.
Now we're even.
Well, maybe I shouldn't ask the question, but we know that there are, in your looking at this, how often is there a really bad result from anesthesia? I'm sure there's a lot of results that are subtly bad, but the ones that are catastrophic, does that happen? And maybe you're about to go there, so.
Yeah, there are a number of problems. We have scar tissue, just simply the muscle is not going to be as flexible as before it was injured. And we have bone structure damage. So we've lost those fibers that are sending signals back to the brain, which hopefully they will start to acknowledge are present and maybe rethink how they will want to do this, or if they want to do this. And eye muscles are not constructed the way we thought they were. And as I said, I think there's brain damage there because you have changed something about the structural nature of the brain and the perceptual nature of the brain because you have moved an eye and head. So the medical approach, of course, starts with, well, if they didn't run through the patching in the glasses, starts with Strabismus surgery. Actually, I had a call last week from a 15-year-old boy, which was odd, first of all. And so I answered the phone. My staff was out that day. So I answered the phone and said, oh, is this where you do eye muscle surgery? No. He said, oh, okay. I said, well, wait, what are you trying to do?
Helpline.
Dog show.
Stop before you do anything.
I said, well, how long have you had this problem? He said, oh, just a couple of years. I said, well, really, you might not want to consider surgery first. I treat the condition non-surgically. What he must have been to my website and seen something to get my phone number. So we spoke briefly, and he said, well, okay, I don't know. I said, well, but really next I would need to speak to a parent. Excuse me. So another one is a woman in her mid-80s, who I have spoken about in the past in some places and written about as well. She first noticed a problem with some double vision at about age 76. It wasn't a big deal until she had cataract surgery, and then the second image became much more apparent. And so the treatment was prism. She started with about 7 to 9 diopters base out prism for esotropia. Alternating, but 90% right eye. So the prism increased over the course of 7 years or so, up to 20 diopters of prism. And then she was told, we can't give you any more prism, you have to have surgery. I think the first time this woman ever saw a doctor was for cataract surgery. She's 86 years old, takes no medications, she's into organic foods, and she's not into surgery. And she and her husband are absolute riot, and they're a real treat to work with. So they started looking around on the internet, and they came across Sue Barrett. And she called Sue and spoke with her for a half hour, and was convinced that she needed to try to find a behavioral optometrist. And when they called my office, luckily it was another day that my staff was out and I answered the phone, they were sold. She's been coming in. I immediately cut the prism to about 12 because we were getting some fusion in a small volume of space at that point, and we're trying to build from there. And she's been with me for over a year now, and pretty consistent doing therapy. We've now got her in 10 diopters, walking around glasses, maybe some computer glasses. The cataract surgeon turned her from being nearsighted to hyperopic. So that wasn't too helpful either. But we actually got over that. We got her back to, I had her in plus 50s for distance and then reading lens and bifocal and with the prism. And after a few weeks, she said, I can't see as well. When I take the glasses off, I see better far away. I'm thinking, that doesn't sound right. You know, you never know what a person's perception of acuity or anything of visual process is. So I sat her down in front of the chart, and sure enough, she was absolutely correct. She was seeing 20/20 without any lenses in the distance. When she came in, she was wearing plus 150 with cylinder, axis 23.5, or whatever it was. And so, strangely enough, I took all that away and got her in spheres, and so that was pretty interesting. But the most interesting was that, as I said, when we met, she was 85. She's very, very thin, and she very hunched over. And we started working. We were doing yoke prisms and just general VT. And one day she walked in like this, and she stayed that way. And she and her husband, he said, I know when she's feeling okay and when she's not, because we're walking around, and I can tell by the amount of pressure on my arm, by her grip, how comfortable she is. And she reports feeling more comfortable in natural terrain where it's not a flat surface, and feeling like she has more peripheral awareness now, and that's helping her open up and start to move. So it's still tough. I think at that age it's maybe a little slower than we like, but generally they're very happy with how things are going.
Did her refractive state change, or was the change in acuity a sign of her improved binocular summation?
I don't know about her refractive state.
Oh, so you didn't check the refractive state when she said she wasn't seeing as well with a plus 50?
No, I just wanted to know she was comfortable.
Okay.
I'm not as anal or myopic as I appear. I'm just very nearsighted. Ultimately, I don't think I scoped initially what she was wearing anyway. So when I see that, I know that there's room for movement, and we're just going to go with. And I may have more details, but it's not on my fingertips. So strabismus surgery, of course, and of course the big question: which muscle or muscles to cut, and I guess how much, where to reattach it. How many surgeries are we talking about? And of course the ever lovely botulinum toxin, the poor man's surgery. Full-time patching, still very much in vogue in certain circles. Again, which eye to patch? I don't think that's a question in surgical. I know some of us that patch the eye that turns, some patch the eye that's straight, and how much to patch. And of course, more surgery is a preference. There are other options. Go blind. What other options? There are no other options. There are some we'll get to. So I was interested in what the science behind the medical approach to strabismus was, and I found it was basically a black hole. So what I decided to do, and why. Early on in practice, I was already hearing this constant tone of there's no science behind vision therapy. And I heard it over and over again, and I thought, at some point I started thinking, well, I want to see what science they have, because they must have some pretty serious science behind strabismus surgery to be saying this over and over again to so many people. So I did a literature search. Actually, I had PCO do the literature search. And they said, oh, we got 50 pages of articles. I said, well, send me the first 10 pages. So I looked through the titles, and I selected what I thought was a pretty good cross-section of what they were writing about in their journals. And I thought, there's not that much there. There was actually, I couldn't discern much of anything there. And so I thought, I would like to put together something for parents particularly, to have at their fingertips, to have access to what I consider to be a more complete picture of what's available out there. I tried to be as objective as I could without being objectionable, and it's not easy, as you know. So I did this, and full disclosure, I do have a personal and financial relationship to the author. But I think it's something that is pretty useful, that can be easily read by the public, to try to get a sense of what is available before they make a decision to do something that's permanent and irreversible. And I think many parents would like that, but as we know, the surgeons are not very forthcoming in what options are available. So this is just a quick list of some of the articles. I did most of this many years ago, and I updated it recently to finally put this into print. So most of these are kind of older articles. I don't think there's a lot of difference at this point. If anybody wants that list, let me know. Actually, or just buy the book because it's in the book. I'm generally not that good at press commercialism, but bottom line is I did all this reading. Somebody else should have to pay for it besides me.
So Emmetrope when he started.
So what my research revealed, it's well accepted by those who perform strabismus surgery that when performing the exact same procedure on two individuals, one should not expect identical results. And those with developmental delays showed even less predictability in the surgical outcomes. I think they meant the patient. And the need for multiple surgeries was discussed very matter-of-factly. It wasn't a big deal. We just do another procedure. It's no big deal.
Get paid again.
And there was almost no follow-up past 4 years. And I think the common wisdom that I'm aware of is that 5 years is kind of the cutoff for a lot of these. That's when things often start to revert or go haywire or whatever is going to go wrong as far as the alignment. That some of the surgeries, will last for 5 years. Well, they didn't go that far out in looking at any of this. In fact, most of them were 6 to 12 month follow-up, and that was it.
Well, wouldn't you expect from their viewpoint that most of these patients are bumping up against that so-called critical period, so there's no need for a follow-up? There's no point to a follow-up.
That's probably a good point. I don't know if that was part of their thinking. I don't know if there was thinking. But I was kind of surprised to see some of this, and this is what drove me to do this because, as I said, I expected to see a lot of pretty rigid, impressive science going on here. I didn't see much of it at all. I didn't see any of it. It was what I consider to be scientific inquiry. So one of the most surprising things I saw was, and this is a quote, look at another way. If the eyes are straight at any time after surgery, the surgery itself has been effective. And I zoomed in on the smallest word there, which is at, strangely enough, because it wasn't for any length of time, it was at any time. So I assumed that they do the procedure, the eyes look straight, spike the ball, game over. And that seemed to be how it was looked at. And these were pretty well respected authors. Most of them surgeons themselves, many of them were surgeons and teachers. So this is what was being propagated out there. The other one article talked about how affordable the surgery was. So I guess if you don't have a lot of money and you're just looking for cheap surgery, strabismus surgery apparently is a good choice. And it was found and had been described as reassuring that there was no significant difference in outcome between surgeons that did hundreds of these procedures a year or somebody who just did it as a hobby. And I didn't find that to be reassuring personally. I found that to be scary. That if the doctors that do this every day, all year, for many years, don't have a better outcome than somebody that says, oh yeah, I'll do it for you. That didn't seem to be a good thing to me. Maybe that's me. So maybe there are other options. There's adjustable sutures. To me, that was the proof that they knew the thing didn't work because they wanted to have another shot at it the next day. So they would put an adjustable suture. And of course, the ever popular Moore surgery, the botulinum. Compensating lenses and prisms, we all know that. They want to just pile the plus on until the eyes go straight. I imagine that they're using minus for exos to try to crank the eyes in. Again, just to try to force something and to have an external device do all the work. And stronger lenses and prisms. Did anybody not hear about this one? Magnetic implants. One, I think, in the sclera, one in the orbit, so that the magnet would hold the eye better, so because the surgery itself didn't quite get it all the way there, so if you have little magnets in there. Now, I suppose you need progressive magnets so that the magnet would have less pull, depending on what's going on, whether converging or straight. So I'm not sure how that's going to fly. That was in, I think, South America they did that. But I'm sure it will become more popular.
Yeah, you can get the tattoo at the same time.
Once, ask your doctor if magnets are right for you. The commercials are soon to be coming out, I have no doubt. Of course, more surgery is also an option. Lather, rinse, repeat. Maybe there are other options. Some of you may have heard of vision therapy. So again, just sort of basic stuff. We're looking at eye movements, at eye-hand procedures, eye-hand coordination. I use peg wheel quite a bit. I use it with minus lenses, with plus lenses, monocular, binocular. I'm going to push all the buttons. The walking rail, and I have an antique Comatrack, or I mean not a Comatrack, the AccuVision. There are newer versions of this. I know people are probably aware of this. So is anybody not aware of that last thing, or something like it?
It's like a wing saccadic fixator.
So it's a saccadic fixator, except it's not just a circle of buttons. It's a flat board where lights light up within the board. There's newer versions with many buttons on them as well. I prefer the flat surface. I like this. In fact, with the older woman I mentioned before, this was something that really started to break things loose a bit, because I did it with red-green glasses. So we would alternate which eye had the red and which eye had the green, and only one eye sees the light. Both eyes see the room around it. So that really started to help things move. So trying to get her to kind of think with that other channel in a different way, and coordinate that channel with the body in a way that she wasn't used to for at least quite some time. And again, we didn't know whether the prisms were working or not, because as I've said to her before, there's two ways of seeing single. One is single simultaneous binocular vision. I didn't use that phrase, but the other is suppressing. And I think that she was mostly suppressing rather than fusing. And I think now she's been more annoyed lately because she's getting more and more double vision. And I keep saying this, but I'm not just saying it to, feel free to assault me with this every week if you want, but I think it's because we're getting closer. And because now both channels are staying turned on more of the time, you're seeing what's really happening instead of just using the one channel. And so, basic stuff. I don't have strabismus therapy. I work with my strabismics the same way I work with all my patients. There may be some little nuances here and there, but overall, it's pretty much the same style of vision therapy that I do. And the same type of lens work that I like to do with anybody who's having visual difficulty. And there's a pile of lenses. So I've sort of veered off the rails a little bit into kind of my work a little bit, as opposed to just communicating what I'll do so quickly. So I do patching in the office. I very rarely ask anybody to wear a patch out of the office. If I do, it's only at home. I would never ask anybody to wear a full patch in public, even though Sally looks lovely in her patch. I don't know if anybody knows Peanuts cartoon. There was a whole series on amblyopia many years ago that they did. He did like 2 or 3 weeks of daily cartoons about her wearing a patch. It wasn't in our vein, but it was still interesting. But I do a lot of very narrow binasal occlusion. And
2 millimeters, right?
I do a lot of patching in the office because my catchphrase is eyes are people too. Because if a person's, any relationship is better if each partner knows himself and then knows their partner. So I feel like using the patch in the office under specific controlled conditions provides an opportunity to do things in a way that you would not normally have access to, because you have both eyes open. If you are competent visually, then you're just doing your thing. If you're less than competent visually, you're probably fighting it much or some of the time to try to get things working the way they're supposed to. But you don't have access to some reasonable period of time of seeing what the similarities and the differences are between the two channels. So it's trying to build a relationship between two partners by allowing each partner to observe itself in action and then allowing the other partner to observe itself in action so that the information that's going back and forth is more complete in a way. That they can start to have a stronger, more complete relationship. So that, I spoke about this on the list and it was sort of misinterpreted that I was trying to equalize the two channels. And I'm not trying to equalize the two channels. I'm not looking for them to be equal necessarily. I'm looking for them to know each other. I'm looking for them to have information, to understand the similarities and differences that will provide a better foundation for integration of the two channels. And I'm not trying to balance the brain. So that got mixed up in the language or whatever it was, but that's not what I'm after. So again, just real quickly, I came up with this little triad here that I thought was kind of neat, that it's insufficient to talk about the eyes without talking about the role of the brain. It's insufficient to talk about the role of the brain without talking about the role of the body. And, excuse me, it's insufficient to talk about the body without talking about the role of the whole person. And I think we do this, but sometimes it's nice to have, like, I try to come up with simple wording that gets some points across, especially talking with patients, because obviously they don't have our level of language relating to this context. So my catchphrase for vision therapy is, it's a program of activities to help the brain use the eyes more efficiently. So this I just like to put up there. I think this was very much in line with everything that was going on this weekend, that from Carl Perburn. What's stored in the cortex is actions. And actions are images of achievement, and the brain stores the intended change in the environment, not the specific muscle or individual movements. It's a global holographic type of event. And similar thought, feeling here. And thank you again for your attention.